What I'd like to do is talk about what I think is one of the most important topics that gets ignored in healthcare, which is the last hours of living. We spend so much energy celebrating the arrival of a new child who has no history, but we get excited about it. But we don't get very excited about saying goodbye to somebody who's had an amazing history when we should be celebrating the life of the person who has been and who will finish their life with us. So let's talk a little bit about the last hours of living. The reality is less than 10% of us will die suddenly. Most of us are going to have a prolonged illness experience. In that illness experience are unique opportunities, but also risks if we don't get it right. What we hear from people over and over again is they don't fear being dead. What they fear is the dying process. And most people have this exaggerated experience of what dying is going to be like because of the media, but it's not like that at all, is it? You and I know that. So first of all, I'd like to start off with preparing for the last hours of life. That's something you can definitely do, is look after and help the person prepare for the end of their life. I'd like to introduce you to Jamie Brown, who's going to be interviewed on video by a colleague of mine, Charles Van Gunten. You can see what she was like in life as a school teacher, vital, full of life. She loved life. And then she got what she thought initially was a shoulder injury, but it actually turned out to be advanced amyotrophic lateral sclerosis. And Charles is actually interviewing her at her request. She wants to tell her story very close to the end of her life. Let's listen. We're going to see several short interviews. Let's listen to Jamie.
Well, I have to intensify. I have to focus on quality rather than quantity. Kind of cut to the chase. I feel like I've become blunt, excessively blunt, maybe, and I don't have time to waste.
I've become blunt and I don't have time to waste. I've got things I need to do. So the question becomes, what should we be helping our patients complete before they die? Do you have a comprehensive list? Do you help people with their advanced care planning? Who's going to make the medical decisions if Jamie's not able to do that for herself, if she loses capacity? And what does she want her care to be like? I know in India there's a challenge with ventilators, but does you really want to be on a ventilator? Or would you rather I avoid that at all? And then if you're on a ventilator, do you want me to stop it if I can't reverse your illness? A lot of people would say, yes, absolutely. What about the finances, the bank accounts, the business power of attorney, the will, the guardianship, social issues? What about dependents and pets? Those reminiscence, the rites, the rituals, the prayers, the opportunity for people to remember what life has been like and celebrate the person. And then, of course, there's the whole issue of where am I going to die and what will my care look like? For Jamie, that was a huge issue because she needed care 24 hours a day, 7 days a week. She couldn't look after herself. And then for many people, they want to think about their funeral, their memorial service. Now, I know within Hindu tradition, within Islamic tradition, there are particular traditions that need to be followed. How do we make sure people don't miss those opportunities? And of course, for everybody, there's an opportunity for body and even organ donation. And even with metastatic cancers, an opportunity to donate cornea as long as it's not melanoma. Are we giving people that opportunity to give the gift to somebody else? And maybe you've got a digital footprint today? Do you? How many of you have social media accounts? Many of us have Facebook, we have bank accounts, we have emails. Who has your passwords? Who has your login information? We need to talk to people about this because the reality is when you die, this all becomes frozen. It's out there. Facebook is going to become the largest graveyard in the world by 2050 because people's accounts are frozen and nobody can access them. So I personally have an if I die file and it has all my login information. It's a challenge to keep it up to date, but it's really important. And what about that opportunity for people to say goodbye? Ira Byock has talked for many years about the need for the person who's dying to say to the family, I love you. I hope you love me. I forgive you. I hope you forgive me, and goodbye. Profound words. And from my own personal experience of my partner dying, being empowered to live my life, I will always love you. I hope you will never forget me. My partner said, please find a new partner for your life and have a very successful life. And that was in 1990, a long time ago. But in the experience of losing a loved one, a partner, a wife, a spouse, a husband, do people get stuck in the I'm still married? Or do we empower them to move on and have a new life? That's so important. Now, of course, there's this issue of fear of dying. Was Jamie afraid? Let's listen.
You know, I really don't fear death because of my faith. I believe that if I can get through this hard part, then what's going to come next is going to be more incredibly amazing than anything I could imagine. And even I don't have words to try to describe that. But what I am afraid of is getting from here to there.
So again, back to that, are you afraid of dying? Yes, the process, but not being dead because of my beliefs, my spiritual perspective. So important. So how are you and I gonna manage the getting from here to there? Managing the dying process becomes core to our skills. I'd like you to listen to this video. It's a short one again. Alice is dying of aspiration pneumonia. Listen for the signs of the dying process and listen for the issues that you and I need to manage during the dying process.
She's just not even responding. She's just been laying here. She's been sleeping all day long, and she made some kind of weird noises in her throat. It just really scared me.
I understand. So what I understand you to say is that over the past few days that she's been weaker
Yeah.
and that she's been sleeping more, although she's had periods when she's been awake and she's been able to eat and drink a little bit and take her medicines. But the day that you haven't been able to wake her up.
And her hand, I mean, her hand has just been like really cold.
Well, I noticed the changes in her hands too. I noticed they're more cool and they're a little bluish. When I feel her pulse, it's quite weak. It's very thready. And when I watch her breathe, I see that it's very shallow. You notice it's just very gentle. So I think what I'd like to do is examine her, and then maybe you and I and Maureen can talk about what I think is going on in the living room. Would that be all right?
Okay.
Well, Melissa, Maureen and I came over because of the changes in your mother. And Maureen's been your hospice nurse for the last several weeks. I'm wondering what you're making of what we're seeing with your mother today?
I don't know, I feel kind of confused.
Mm-hmm.
Because I thought that she would just keep going on the way she has been, but now she really seems different, like things aren't right.
Mm-hmm.
I'm kind of worried, you know, if she can't eat, then she's going to just get worse, and I don't want her to just get worse, so, I mean, maybe we need to give her, you know, an IV or something like that.
Mm-hmm. Mm-hmm. We could do an IV,
Mm-hmm.
but I don't think it would make her better.
I thought maybe you would say something like that.
Did you?
Yeah.
Melissa, I'm afraid your mother's dying. I'm not sure exactly, but she may be dying in a day or two.
Like that soon?
It could be.
So, no matter what we do now, it's not going to help.
No, I don't think anything we can do can stop her from dying. With the changes that we're seeing today, the changes in her breathing, the changes in her hands, makes me think that her body is shutting down.
What can I do to help her?
Well, I think it's important for you to remember that there's a lot of things that you can do for her. And some of them you've already been doing. You've been keeping her mouth clean with the swabs that you've been using. And you've been making sure that her skin stays clean and dry. And you're going to continue to do those things. You can turn her on her side and put a pillow at her back for some support. And that will help some of the secretions that you've been hearing in her throat drain out. So I think it's important for you to know that you're doing all the right stuff.
Okay. I thought that I would have more time with her or something, I guess.
That's the way many people feel. It's never the right time.
Yeah.
As Maureen said, you've been taking a wonderful job taking care of her. As you know, she said that she wanted to be comfortable and she wanted to die in her own home, in her own bed. And you're helping her do that.
Is she in any pain?
I don't see any signs of pain.
Okay.
I think if she seems like she's in pain, if she's grimacing, we can still give her some of the liquid pain medicine just inside her mouth, inside her cheek.
Will people help me with this?
Well, I can contact the social worker at hospice and he can make some phone calls and we can certainly get some caregivers in here to help you out. That way you can just continue to be her daughter, loving her and not giving her 24-hour care.
Okay.
So I agree with Maureen. There are many things that we can do for her right now. I think she can hear you. I think she can feel your touch. Most people are afraid of dying alone and dying in pain. I think you can assure that neither of those things happen to your mother. That's a lot.
Okay.
What other questions do you have for us?
I guess just to know that you'll be there.
I may not be able to see your mother again before she dies. You can certainly get me by phone, and Maureen can get me by phone. But the hospice team is going to be able to be here to help you and your family through this. I'll be sure to give you a call, and so we can follow up.
Okay.
Okay?
So I hope what you can hear in this brief interview is the complexity of the issues that we need to address as we enter the dying process. It's not just the person is unwell. We actually see signs of the dying process and we make a new diagnosis. It's not just that change in consciousness, but it's the associated changes in breathing patterns, the loss of ability to swallow and the absence of gag reflex, if you test, the buildup of secretions, maybe it's the change in mental status, the delirium, maybe it's loss of sphincter control, or is it the cardiac output failure that may even lead to the renal failure? Now you'll notice I've highlighted changes in breathing patterns, loss of swallow and gag. If these are new, these are pathognomonic and diagnostic that the person is now really dying. And of course, you as pulmonologists would recognize these different types of patterns. Sometimes they occur much earlier in the person's illness experience. There's also a series of issues that we need to manage the weakness, the fatigue, the change in appetite, the cutaneous ischemia that can lead to skin breakdown, that cardiac and renal dysfunction that can lead to buildup of toxins, the neurological changes, the pain, and people get really startled when people can't close their eyes. We need to understand why. So let's unwrap each of these. The first is to recognize that you and I, as we approach the end of our lives, are likely going to be weaker and fatigued. We're not going to be able to move easily. We're going to need help with our activities of daily living, the bathing, the toileting, the feeding, the transferring. Now, what we know is as people go to bed, it doesn't change the proprioceptive neurological system, which has sensors in our joints and our muscles, which are designed to warn us and get us to move. People get really painful and achy muscles and joints. If you haven't done it, I suggest you lie in bed for half an hour and don't move anything. I bet you can't do it without getting very uncomfortable. So what we need to be doing is teaching the caregivers passive range of motion, keeping somebody moving. And of course, we need to make sure we're turning them routinely and providing massage to reduce the risk of pressure ulcers. I'll come back to that a little bit later. There's that decreasing nutrition and fluid intake, which distresses everybody. Because, of course, aren't fluids and nutrition a sign of love? People have been feeding each other for years. And now you can't eat? Oh my goodness, does that mean you're going to die? Are you giving in? What you and I need to remind ourselves and them is that food can actually become nauseating. The anorexia leads to ketosis, and one of the ketones is actually an anesthetic agent. It can be very protective. And of course, there's a risk of aspiration. I don't know whether you've ever had that happen to your patients, but I certainly have, and it's awful. This particular family, I'm thinking about the son who was 24 years of age, who'd given his father some yogurt, which he's aspirated, and his father died. Thought he'd killed his father. It was horrible. So what I say to people, if the patient has their teeth clenched, it's their last way of exerting control. Don't push. What you and I need to do is teach the family how to do this. We need to talk to them about small plates, small quantities, preparing person's favorite foods, or maybe not at all. We need to tell them that patients who are not drinking, and many of our patients still have a lot of fluid on board, some of them even have peripheral edema, while they're afraid the person will be dehydrated and thirsty, they may not be. Thirst is actually driven by a dry mouth. Again, dehydration by itself can be very protective, releasing endorphins as well as the ketones that may themselves be anesthetics. But particularly you and I need to, if somebody's got a dry mouth, manage the mouth breathing. We need to make sure that we're keeping the mouth moist and doing good oral care. I suggest Vaseline or another petroleum-based product could be one of those lip sealants to protect the cracking in the lips, and using a baking soda mouthwash to moisten the mouth. Now, of course, there's that decreased cardiac output, isn't there? And you and I need to recognize that as the volume of urine goes down as a result of all of this, that parenteral fluids can actually be harmful, not helpful. And we need to recognize that when a patient gets below 500 mils of urine output, which is amber, or 250 milliliters of urine output, which is now dark brown, that fluids will go to the wrong places. And the worst wrong place, of course, is the alveoli. Now, many of our patients also have hypoalbuminemia, and that also means the fluids go to the wrong place. So what you and I need to be careful about is that we're not giving fluids in the face of hypoalbuminemia or anuria or oliguria. You need to be careful about the volumes. So how much fluid can you give? Again, you need to know the science of fluid loss, even in the face of no urine output. You and I lose through perspiration and respiration about 250 milliliters of fluid per day by each route, a total of about 500 milliliters per day. So you and I can safely, if the family insists on an IV, we can safely give 20 milliliters per hour. Most families are not watching and counting the drip rate. They're just happy that there is a drip. And so it becomes a bit of theater to keep the family happy and to make sure that we don't overload the patient. Now, clearly, if the patient still has some urine output, you can replace the urine output volume as well if you need to. But I would say if you don't have an anxious family, don't start an IV. You don't need it. Again, the ketones, the endorphin release can be protective. What we do need to do is keep the mouth moist, the nares moist, the eyes moist. I like a baking soda mouthwash. You can see it's 5 mils of baking soda with 5 mils of salt in a liter of water. Keep mouth moist. And use the Vaseline-based product to coat the lips and the nares. And use some ophthalmic lubricant that you could buy in the pharmacy to keep the eyes moist if they're open. So what about the neurological dysfunction? One of the experiences is loss of ability to swallow. And you can imagine for a patient with amyotrophic lateral sclerosis, this was a big deal. Let's listen to Jamie and hear what it was like for her.
Lots of times it's scary. I've had a lot of trouble with the mucus in my throat that is often present with ALS. And I'd heard about air hunger, that feeling of suffocation and not being able to breathe. And now I know what that's like, because lying in bed at night with my arms totally paralyzed and under the covers, I can still move my fingers a little bit, but I can't do much with moving my head, and I have to be able to reach the call light. So I've often been panicked and terrified when I feel that in my throat and I don't have the muscles in my throat anymore to either swallow it down or cough it up.
Often panicked. Now, I use Jamie because she tells her story so beautifully. And of course, she experienced this before she was dying. But can you imagine having some level of awareness, but you can't clear your secretions because you've lost your ability to swallow and your gag? Are many of our patients going to be panicked about this, but they can't express it because they can't communicate with us? You and I need to be very aware of this. So I remind you that this neurological function of our ability to swallow, our ability to cough, clear our secretions is coming from our cranial nerves. And what's happening if people are losing this ability, is not only is cortex failing, but now our brainstem is failing, particularly at the level of medulla. This is a fundamental neurological function. Most of our secretions are coming up from our trachea and our lungs because, of course, fluids are constantly leaking from our vascular space into our alveoli, and we're constantly clearing them in life. Coughing, cilia are moving fluids up. These patients can't do that. So what we need to do is either postural drainage, turning them on their side, and I do that very frequently with my patients, to drain them out, to get rid of those secretions. We could just reposition people. What we know is suctioning is really not effective because it only goes into hypopharynx, and the majority of the secretions are much lower down, often beyond our larynx. Alternatively, what we can do is use medications to deride the secretions. One of the anticholinergics, maybe you've got glycopyrrolate, scopolamine, atropine, all of these can be very effective. The distinct advantage of glycopyrrolate is it does not cross the blood-brain barrier. It may not add to any confusion, whereas scopolamine and atropine both cross the blood-brain barrier. As anticholinergics in the elderly, they could add to that change in mental status. Now, because these all have a half-life of about 8 hours, you can use bolus dosing, or you can deliver them by infusion. And again, what I will do is titrate to effect. If I'm giving it subcutaneously, I can give it every 30 minutes. I'll typically give a dose of 0.4 milligrams to start with. Some patients require more, and I combine that with the postural drainage to get rid of the fluids in the first place. And then I want to keep the secretions down. Now, of course, if somebody has a level of alertness, they'll hate the dry mouth that ensues. So you and I need to be pretty aggressive about the mouthwash and the Vaseline that we're using. Alternatively, we could use a scopolamine patch. Those are available in some settings, but they're low dose. You probably need 3 or 4 patches. Now, of course, breathing was also an issue for Jamie. Let's listen to her experience of changes in breathing.
I never thought that I would be using drugs like morphine, but it really does help. And it helps relax the throat muscles. It helps me to relax and not tighten up further and the working muscle that I have. It helps with pain. It helps put me to sleep.
So morphine works. What we know, again, is the breathing control center, which is again in our brainstem, is actually surrounded by morphine receptors. There are multiple in the region. Now, you and I get inputs that continue from our intercostal muscles, our diaphragm. We get inputs from our face, the whole cranial nerve area. We also get inputs in terms of the chemoreceptors. And if any one of them is out of balance, you and I are going to feel short of breath. Now, you could recognize when the change is occurring by these types of breathing patterns. And I will say that if Cheyne-Stokes respirations are new, it's absolutely pathognomonic if this patient is dying, just as the loss of ability to swallow and that loss of gag. Pathognomonic. This person is now in the process of dying. If we can't breathe, we can't swallow our secretions, we're not going to survive. Of course, there's a huge amount of fear around this. I don't know about you, but this is the thing I fear the most for my future. What we do know is that opioids in very low doses, 5 milligrams of morphine orally, equivalence is 2 milligrams subcutaneously or intravenously, is enough to settle most people's experience of feeling breathless. What we do also know is that oxygen won't necessarily help. If somebody is desaturating, it can be useful, but otherwise, what's the real effect? It's actually the flow. When people experience the air going across their turbinates, or even better, across their face. I don't know how many of you have actually been on a plane flying. Did you reach up and open up the air so that you could get the airflow and then you felt more relaxed? We have clear evidence that using a fan and simply circulating the air is more effective in most patients than actually spending the money on oxygen. Now, I do want to finish this off by saying Jamie wanted to tell her story. Everybody thought she was going to live for quite some time, but because she'd said her story, she died, quotes, unexpectedly, even by her nurse and physician a week after the interview. Again, people have a story they want to tell, and when they've told it, they often let go. So how can you and I facilitate this? It's important to focus on the reminiscence, the storytelling, getting the people to the bedside will really make a difference for the patient and allow them to let go. Now, what else do you and I need to focus on? Well, of course, patients in the process of dying, they have changes in their neurological function, altered mental states, and they may get terminal delirium. I really like this particular diagram coming out of a paper many, many years ago. It really illustrates that people die along two different pathways. Fortunately, the majority of patients go down this, what I would call the usual road. I'm going to say in my experience, it's 70 to 80% of patients, and that's a hypoactive delirium. Please label it. As doctors, you and I need to use the words delirium, and whether it's hypoactive or hyperactive, or maybe it's mixed, put it in the chart. It's not a nursing diagnosis. They will say anxious, irritated. Of course, this is the patient on the usual pathway that nurses love, the quiet sleeping patient who wakes up intermittently. But as we know from interviewing patients who've had a hypoactive delirium, their suffering can be profound. Hallucinations, nightmares, bad dreams. Again, it's important to recognize that the part of our brain that hears is different from the part of our brain that processes information, is different from the part of our brain which allows us to express information and reach out. It's the expression which goes away first, but the processing may continue and the listening may continue. So even when the patient's on the hypoactive pathway, we need to think about managing it because people may be suffering. Now, if they're on the hyperactive pathway, my experience, 10, 20, 30% of patients, just a rough estimate, this is not a happy place for the patient or the family or the caregivers or the staff. Isn't this when your staff in the hospital get really agitated themselves? Do something. So we need to do something. If it's a hyperactive terminal delirium, the difficult road, what's important is for us to settle the patient. Think about it. It's the patient who's moaning and groaning, maybe moving. We want to stop the phonation. We want to stop the movement. We want to make sure the person has amnesia. Oops, sorry. So what you and I want to use in this case, which is not indicated for normal delirium, benzodiazepines, the backup are barbiturates and propofol. And this medications to use and the dosing are on the palliative cards that I sent you for the irreversible delirium. Now, why benzodiazepines are particularly perfect is because they are anti-agitation, they do sedate, They're anxiolytic sedatives. Most importantly, they inhibit short-term memory production. They're amnestics. They relax skeletal muscles, and they will protect the patient. They're anticonvulsants. So particularly if we have patients with intracranial disease, it's important to make sure they don't have a seizure. Having a seizure at the last time in life, those last few hours, is an awful situation for everybody. Now, I put down the contrast with antipsychotics because, of course, using haloperidol or risperidone or olanzapine, quetiapine may be appropriate for us to use in the potentially reversible delirium. It's not going to help us here because it's not an amnestic. It doesn't relax those skeletal muscles, and those vocal cords are skeletal muscles. We want to relax them so we stop the phonation. And please, never, never, never use opioids to manage the delirium. The sedation from opioids are adverse effects. And in my experience, if you're using an opioid at the end of life for a patient who does not have pain, and you're titrating the dose, you'll actually make it worse, the delirium, make it worse. And this will be the fastest way for the medical examiner to be interested in looking at your charts and your practice. So don't do it. At the end of life, for the agitated delirium, benzodiazepines are the choice. I like to just use very low dose of lorazepam, or you can use any one of the complementary benzodiazepines. I give 1 milligram, pre-dissolve it in a bit of water, place it up against buccal mucosa. If I'm able to, I do this in the home all the time. Wait an hour. If not effective, I give another dose. If 3 doses ineffective, call the doctor and I double the dose. And then I need to recognize that lorazepam's half-life is 12 hours. So once I get control, I dose every 12 hours to keep at a steady state. There are no clearance concerns, so I don't have to worry. I could also use midazolam. For time, I'm not showing you all the details. And here's my strategy for giving it against the buccal mucosa: taking out the plunger of a 3 ml syringe, putting the tablet in it, pulling up 1 ml of water, 1 ml of air, and shaking for it to dissolve, and then placing a glove finger and placing it in the buccal mucosal area, never passing fingers through teeth. Important that we teach families to do this. They can do it easily themselves. Now, of course, midazolam I could be using. Need to recognize it has a very short half-life, so now I need to dose it by infusion. Of course, I could use a bolus to get started. Now, of course, the question people say is, well, with these benzodiazepines, are you hastening the patient's death? And the answer is no. First of all, I'm trying to achieve amnesia, settle the confusion and restlessness. I don't care about the hypotension. It's a part of the dying process. And respiratory depression is just not an issue. We know the LD50 of all these medications. It's the lethal dose for 50% of the rats. And you need to know the numbers. They're huge. I told you I'm going to use 1 milligram or 2 or 3. Typically, it's anywhere from 2 to 10 milligrams of lorazepam to settle a patient. Midazolam, the most I've ever used for a compassionate extubation when the patient was naive to midazolam, is 10 milligrams. Most of the time, 5 milligrams intravenously is just fine. These are tiny doses compared to the doses of lethality. I am not hastening anybody's death. Now, what I showed you on the cards was when benzodiazepines fail, our backup is propofol and phenobarb, and the dosing formula are on the reference cards I sent you. If you need more details, we're happy to provide that, and I'm sure a palliative care provider in your community would be happy to help you with that. But I'll tell you, I've used propofol in my 35 years of doing palliative medicine. I've used propofol twice, and I've used phenobarbital probably 5 times. They were much earlier in my career, because today I think we don't see some of the horrible, horrible local disease we used to. Now, you may still be, in which case you may still be needing to use it. It's fine, no problem. The strategies are on the cards that I gave you. Now, what about that hypoactive, that quiet sleeping patient? Are they suffering? It's a good question. And it's kind of hard for us to know because they don't tell us unless they wake up for a bit. And there are some patients that wake up and say, oh, I saw grandmother coming to get me, or the puppy dog. It was all very pleasant. I'm not sure we need to treat those pleasant hallucinations or dreams. But if the patient is suffering, again, do I need to use a little bit of medication? If there are bad dreams, nightmares, hallucinations, paranoia, is that something that you would like to experience if you're dying? I suspect not. I'm certainly very clear. I don't want to experience the dying process. So let's ask our patients in advance, because we know delirium effectively occurs in 100% of patients, whether it's hypoactive or hyperactive. And you and I need to be prepared and find out if they want to experience the dying process. Now, I say this particularly because there are several groups, including Buddhists, who say, no, 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 I don't want medications. I need to experience crossing over. So we need to ask who wants to experience and who wants medications. So, of course, this is a profound question for us to reflect on, isn't it? Would we want to experience a hypoactive delirium if it's got bad dreams, hallucinations, nightmares? I'm clear I don't. What about you? Should I give you a low dose of benzodiazepine to ensure amnesia? I'm really clear. Yes, please. And a milligram or two of lorazepam or an equivalent of another. You can use alprazolam, clonazepam, any one of these. It'll do the trick. Keep me comfortable. I do not want to experience this. But of course, there's pressure from families, isn't there? What about communication with that unconscious patient? Well, again, I said it before. We need to recognize that people hear through one part of their brain, they process through another part of their brain, and they respond and communicate through another part. And the part that allows people to communicate with us is what fails first, but they may still be thinking and hearing and listening. So what I like to make sure is people understand this, the family, the caregivers, and that we include people in the communication. Good news at the bedside, challenging news behind a closed door somewhere else. Now, our anesthesia colleagues use the eyelash reflex, or corneal reflex, but they use the eyelash reflex, most of them, to establish whether a patient's anesthesia is deep enough that they are unaware of what's going on. This is, again, a primary reflex in our brain stems, which allows, if we touch the eyelash, we get a flicker. When the eyelash reflex is absent, what we know is there isn't cortical awareness. So this can help us establish in the dying patient, is there cortical awareness or not? I'll even teach this to families. Well, look and see. If they have a reflex, you can assume there's still some cortical function. Afterwards, if there's no eyelash reflex, there's probably no intellectual awareness. So create that familiar environment, assume the patient hears everything, include them in the conversations. And of course, there's touch and music that can really make a difference. I've seen patient after patient over my career where they're unable to respond, but clearly they're taking in the information. Many are waiting for somebody to arrive, and you see them settle when the person arrives and often die at half an hour or an hour later. Or you hear a bad news conversation and people get agitated. The patient gets agitated. You can see them start to fidget. If you look at their pulse and their blood pressure, it changes. So again, they're probably listening. We don't know because they don't come back and talk to us. So it's then important for us to be able to say those goodbyes that Ira Byock described, to give people permission to die. And you and I may need to teach the family how to sit down and say, my dear one, it's okay if you die. I'm going to be okay. We've seen family struggling with this, but when they finally settle and they give permission, we see the patient often die a few hours or a day or two later. Again, we need to teach them the words of giving permission and saying goodbye. Of course, that's hard for people who are grieving. But can we get them there? That's the best of palliative care, because then people who survive the family will remember all of that. And it doesn't matter if you've done wonderful pulmonary care throughout life and you don't get the dying process right. People remember the bad dying. They forget about the really good care you provided. That's what sticks with them for the rest of their lives. But of course, there's the issue of pain, isn't there? Does pain get worse? I'm going to suggest to you, because pain is about perception in our thalamus and other parts of our brain, we have a fear that it's going to increase, but it actually probably isn't. And what we do know is that we should assess the unconscious patient. It's particularly here, the muscles are the last place to relax. And if I have constant grimacing or fleeting expressions, maybe I have pain, maybe. But of course, I can have gas and get that, or I can be having a bad thought and get that. If I see that, maybe an opioid is helpful. If I don't see that, don't use an opioid. The restlessness, the agitation, the calling out is probably the delirium, not the pain. Because I don't think that pain gets worse as people are dying. In fact, it stays the same or probably gets less because their perception changes. It's not as though the physiological inputs from the proprioceptors, whether it's the tumor or the arthritis or whatever, they don't change. In fact, they become less active as well. So it's important to differentiate between real pain and whether it's terminal delirium, which is very common. Now, what about the whites of a dying patient's eyes? What's that all about? What's the pathophysiology of that? Well, it's pretty straightforward. Most people think it's neurological. It is not at all. This is about the amount of fat behind our orbit. People lose the retroorbital fat pad. The orbit is being pulled backwards by muscles. We don't have enough eyelid to cover our eye. We grow our eyelid just to oppose, and when it goes back, there's not enough eyelid. So we see the whites. And in fact, neurologically, these people are often moving their eyes, so there's no light impacting on their pupil. So, of course, you and I need to be aware of dry eye. Ophthalmic lubricant becomes all important here, offering it every 4 hours to keep the eye moist, because a dry eye is horrible. Remember that if we're using artificial tears or even a contract lens solution, we get evaporation probably every 15 minutes, it'll dry out. Not helpful. You need an ophthalmic lubricant. But you also need to teach families why this is occurring. It's not as though the patient is suffering, as long as their eye is not dry. It's going to be fine. So what about turning patients? There's mythology out there that we should be turning patients every 2 hours. It comes from Florence Nightingale, who was the first nurse who described this, which was really about how long it took her to go around the ward and come back again. It's got nothing to do with the pathophysiology. Our skin will survive pressure and ischemia for very short periods of time. In fact, probably better that we're turning patients every 30 minutes, stimulating blood flow by massage, making sure we're doing that passive range of motion, pillowing people to reduce the pressure, and making sure they're on an appropriate closed cell mattress that's thick enough. What I like to say is, if you've got a mattress the patient is on, you should be able to put your hand underneath and feel at least 2.5 centimeters of foam that's compressible at the lowest point of the patient to make sure they're on enough pressure reducing foam. Many of the foams that we can buy in pharmacies just aren't enough for the patient. So we need to get family turning the patient regularly. And I like to get people turned every 30 to 45 minutes, still trying to minimize skin breakdown. And what about medication use? Well, most medications we're just not going to need, are we, at the end of life? In those last hours of life, it's a time to stop things. Please use the least invasive route of administration. You can use the buccal for morphine. You can use it for the benzodiazepines. It's fine. If you really need an infusion or an alternate route, please use the subcutaneous. You don't need the IV route unless the patient's already got IV access. And I don't like intramuscular at all because it's painful. You just don't need to do that. Administering medication subcutaneously works as well as intramuscular. And remember the kinetics. Medications by these different routes of administration take different times to be absorbed. And of course, if the person has cardiac output failure and things are slowing down in terms of blood flow, it may take a little longer. Subcutaneous is 30 minutes to get to Tmax, maximum effect, maximum risk of side effects. Orally, it's an hour. And even delivered buccal, morphine or the benzodiazepines are the ones I'm using at the end of life. It works. After about an hour, you start to see the patient settling. You can give another dose if they're not settled. And remember that the half-life of morphine is 4 hours, but you need to know the half-life of the benzodiazepines. It's 12 hours for lorazepam. For clonazepam, it's 30 hours. You got to look it up on the tables. And of course, understand the kinetics will be at steady state after 5 half-lives in terms of routine dosing. The other piece that I'd like to remind people of is, if you're using morphine, and I know that's quite common, at the end of life, you need to be aware of the fact that morphine flows with the fluids. It is passively cleared in our urine. If we have urine volume output, out it goes. If we don't have urine output, which is what happens at the end of life, it isn't cleared. Now, morphine is broken down into 2 different metabolites by glucuronidation in our liver. And in my experience, unless we have profound liver failure, we're still producing the glucuronides. The morphine 6 is the analgesic. And as long as I have given it and I have it in my body, I have analgesia until the patient dies. What I don't want to do is give too much morphine, because you'll notice the morphine 3 is responsible for the excitation, the bad side effects that we don't want, which can include hallucinations, delirium, confusion, drowsiness, etc. I don't want to give more morphine and overfill the patient's tank. From morphine's perspective, you and I are just a bucket of water. We put it in every 4 hours because we pee it out. If we stop peeing, we need to start putting it in. So what I like to say is if patients have less than 500 mils of fluid output in their urine, at least decrease the routine dose by 50%, or even stop the routine. If they have less than 250 mils, which is that dark brown urine, stop giving the patient morphine. They will still have morphine cycloglucuronide on board. They will have analgesia until they die. What we don't want to do is give them excess analgesic, because we'll give them morphine 3-glucuronide and we'll throw them into delirium. And before I understood this, we used to give excess morphine, and of course, people's delirium got worse and worse and worse. It was when we started transplanting patients that we learned all of this pharmacology, and we learned we really have to stop giving the morphine at the end of life. Everybody remembers what happens during the last hours of life more than any other time. You and I need to get it right. So we need to focus there.